Hi, everyone. Thanks for joining us for our final What's New in Addiction Medicine talk of the academic year. My name is Sukhpreet Clare. I'm the Associate Program Director for the BC Center on Substance Use Addiction Medicine Fellowship, and I'm very excited to welcome Dr. Victoria Tian, who is a fifth-year General Internal Medicine Fellow at the University of Saskatchewan and one of our Addiction Medicine Fellows this year, who's going to be presenting on liver transplantation in alcohol-associated liver disease, which I'm really excited to hear about. Take it away, Dr. Tian.
Thank you very much for that introduction. As Sukhpreet said, today we will be chatting about liver transplantation and alcohol-associated liver disease. Before I start, I like to say that I have nothing to disclose. In terms of the outline for today's talk, I like to chat about alcohol-associated liver disease, the spectrum mispresentation, the prognosis associated with this disease presentation. Also chat about the history and the changing practices in liver transplantation for alcohol-associated liver disease. And finally, I like to chat about the role that addiction medicine providers can play in alcohol-related liver disease and liver transplantation in general. Before I get started, I like to respectfully acknowledge that I'm a humble guest on the unceded traditional territories of Musqueam, Squamish, and Tsleil-Waututh nations. Okay, so let's get started. So alcohol-associated liver disease describes a spectrum of liver injury from alcohol use. Alcohol-associated liver disease is a major cause of liver disease worldwide, both on its own and as a cofactor in the progression of other liver diseases. Alcohol, of course, is the main toxin driving this spectrum of disease. Cirrhosis, mortality, hospitalization for alcohol-related liver disease we know is directly related to alcohol consumption rates. We have data collected by Statistics Canada showing that each liter in alcohol use is associated with 16% of alcohol-related cirrhosis deaths in men and 12% in women. Unfortunately, 1 in 5 Canadians age 15 and above meets the criteria for alcohol dependence or abuse in their lifetime. And unfortunately, the global trend in Canada, but also globally, for alcohol consumption is increasing, especially as we know in the context of the COVID pandemic. So the damage done to livers and obviously the rest of our body is not going away anytime soon. The natural history of alcohol-associated liver disease goes through several stages. Begins with a normal liver, but certainly with ongoing alcohol consumption, especially heavy alcohol consumption, we begin to have hepatic steatosis, alcohol-associated fatty liver. This can be seen in 90% of those who are heavy drinkers, and it can happen as quickly as in 2 weeks, but it does rapidly resolve with 4 to 6 weeks of abstinence. Unfortunately, the next stage in progression of alcohol-associated steatosis is something called steatohepatitis, for which the clinical correlate of this would be alcohol-associated hepatitis for those who do continue to drink. And of course, ongoing drinking may also cause fibrosis in the liver that could lead to cirrhosis. The interesting or unfortunate thing about steatohepatitis is that some patients can have very severe presentations where they present with acute liver failure or acute on chronic liver failure in the context of already established cirrhosis. And for those whose disease spectrum progresses all the way to cirrhosis, they're also at very high risk of decompensating into acute on chronic liver failure or just decompensate from their underlying progression of liver disease due to ongoing alcohol use. And another important piece to think about is those with alcohol-related cirrhosis may also present or decompensate into hepatocellular carcinoma. In the context of discussion for liver transplantation, some of the more common scenarios for which a transplant may be considered would be for end-stage alcohol-associated cirrhosis, for which triggers may be decompensation or new onset decompensation, such as ascites, encephalopathy, jaundice, variceal hemorrhage, that may trigger physicians into considering for liver transplant evaluation, but also HCC or MELD sodium more than 32. Having said that, there is also a group of people for which they are basically in acute liver failure, as seen with severe alcohol-associated hepatitis, that we will also chat about during this presentation. So to start with the first diagnosis, alcohol-associated cirrhosis, it's important to recognize that cirrhosis is often diagnosed at the time of decompensation, or it could be uncovered during the course of evaluating abnormal physical findings or laboratory tests. Alcohol cirrhosis cannot be differentiated from other causes of cirrhosis except through careful evaluation of drinking history and exclusion of other liver disease. Prognosis for alcohol-associated cirrhosis can be estimated by the presence of decompensating events. And we know, for example, once hepatic decompensation develops, the expected 5-year transplant-free survival rate is about 60% for those who stop drinking alcohol, 30%, unfortunately, for those who continue to drink alcohol. There are also prognosticating scores, such as a Child-Pugh score, MELD score, that can be used, as you would in other liver disease as well. Just to give everyone an idea, Child-Pugh would be ABC. A may confer a prognosis of 100% in 1 year, 85% in 2 years. But once we're getting to the stage of C, which is the last stage, prognosis in terms of survival may be 45% in 1 year, 35% in 2 years, so it can be quite poor. Having said that, we know that the outcome of alcohol cirrhosis is crucially influenced by the patient's ability to abstain, both to slow the progression of fibrosis, but also to minimize or even reverse its consequences. We know on imaging that when patients abstain from drinking alcohol, that there are several characteristics, such as hepatic venous pressure gradients, that will reverse and improve. And there's also data from studies where patients' livers were biopsied, and when looking at risk factors for survival, is actually not necessarily the severity of fibrosis seen on their biopsy, but it's actually 1 month abstinence, or just abstinence from alcohol in general, that predicts survival. So all in all, the ability to abstain from alcohol is crucially important, but people with alcohol-associated cirrhosis can have very poor outcomes should they be end stage. The second entity that I just want to talk about as well is alcohol-associated hepatitis. This is a clinical entity and is characterized by rapid onset of jaundice, by a typical consumption pattern of alcohol without significant period of abstinence, a very typical lab pattern, and elevated bilies suggesting synthetic dysfunction. But at the same time, it's important to assess and adequately address any possible confounding factors that may be at play as well. This is the typical management of alcohol-associated hepatitis that I think a lot of us, especially inpatient, have seen. Basically, upon realizing the diagnosis of alcohol hepatitis, we will often perform lab-based prognosticating scores, the most common which is the Mastery discriminatory function. And the Mastery discriminatory function is important for multiple reasons. Firstly, it is a tool that we can use for threshold of initiating corticosteroids, which do have benefit in alcohol-associated hepatitis, but it is also helpful in conveying and understanding the severity of the presentation. For example, we understand that if it's more than 20, the prognosis, 90% may have prognosis of only 20% in a year, whereas more than 32 predicts 1 month mortality of 20 to 50% in the course of a month. And this is that threshold for indication for steroids. Unfortunately, for those who are on steroids for a week, the failure of improvement as defined by a second lab-based prognostic score, the LAO score, further predicts a poor prognosis and which is as bad as mortality 70% at 6 months. But with a LAO score of more than 0.45, it is also a trigger for recognition that this person has failed medical therapy aimed at alcohol-associated hepatitis and should really be managed supportively, have critical discussions with family. But as you can see here, the combination of the Mastery discriminatory function and the LAO score together is important prognostically, but also in terms of treatment. Having said that, once we are at a stage where we've deemed that the patient is not responding to medical therapy by treatment algorithms, they should be considered for referral for early transplantation or potentially palliative care. So with the context of alcohol-associated liver disease, it's 2 very severe presentations and also its prognosis and certain chance of recovery. I'd like to chat about liver transplantation in alcohol-related liver disease. In general, liver transplantation is an important treatment option for patients with severe liver pathology, such as acute liver failure, end-stage liver disease, primary hepatic malignancy. Alcohol-related liver disease is now an leading indication for patients undergoing liver transplantation in Western countries. It's surpassed viral hepatitis in the early 2000 papers, which was a figure somewhat unanticipated by previous liver transplant experts. Having said that, liver transplantation infrequently cures the underlying disease and is certainly not a cure for alcohol use disorder. That is the driving factor for alcohol-related liver disease. And further complicating is that liver grafts are a scarce resource. At the end of 2018, more than 5,000 patients were waiting for an organ in Canada, and 200 of these were died waiting for an organ. So transplant centers have the monumental and difficult task of maximizing medical utility by maximizing graft and patient survival given the shortage of organs. And so the decision to list the patient for liver transplantation involves a complex risk-benefit analysis. The benefit, of course, being that there is demonstrated improvement in survival at multiple time periods, and we'll chat about all that. And there's also improvement in quality of life. But having said that, the risk of the procedure is to expose the patient to an unnecessary procedure when they could have recovered quite well on their own by achieving alcohol abstinence. There's also significant risk associated with the surgery, infection, bleed, there's also a huge amount of trauma that may be involved in undergoing through these surgeries. But also important to remember in particular is the 1-year mortality of 10%. So patients need to understand that too before consenting to surgery. There is also risk of the recurrence of the underlying disease. And of course, alcohol use disorder is a chronic disease characterized by relapse and remission. So after receiving a graft, a severe alcohol relapse tends to confer a very poor prognosis, marked by a rapid decline in the graft, as the graft is very sensitive to alcohol exposure after transplantation. And there is also the long-term immunosuppression, long-term medical follow-ups that come with receiving a transplantation. But how do patients do after receiving transplant for alcohol-related liver disease? In summary, is that they do quite well. Liver allograft and recipient survival are among the highest for all indications of liver transplantation. 1-year survival is high as 80 to 90%. 3-year survival is about high 80s or about 80s to high 70s. 5-year about 70s as well. And there's some data suggesting that it's even higher than other indications such as transplantation for viral hepatitis or cryptogenic cirrhosis. Amongst people with alcohol-related liver disease transplant, or if they're transplant recipients, I should say, for people with alcohol-related liver disease, the most common cause of death for this subgroup are actually cardiovascular events, malignancies, social causes. The risk of relapse or severe relapse in the first 5 years is fairly low, all things considered, it's only 10 to 20%. But having said that, the graft, again, is very sensitive to alcohol. In this French multi-center study of 700 patients that were transplanted for alcohol-related liver disease, 18% of them had a severe relapse. And they here define severe relapse as more than 20 grams of alcohol a day in women, more than 30 grams of alcohol a day in men for at least 6 months. So these are true relapses. The median time to this type of relapse was about a year, granted with a large range, 4 months to 157 months. Of the people that had this kind of severe relapse, a third of them developed cirrhosis very quickly, about 5 years after receiving transplantation, and nearly 2/3 of these individuals died. And unfortunately, the median time of death between diagnosis of cirrhosis and death is also very rapid, so about 1 year. All that is to say is that we need to have the recognition that prevention of alcohol relapse is incredibly important, especially in the context of liver scarcity. And we're also not doing our patients any favors when and just exposing them to harm as well when we're not able to support them through alcohol abstinence. I just want to chat also about the 6 months rule. And I think this is a wonderful example of how medicine reflects our culture in many ways. For a long time, we had a rather moralistic perspective of substance use disorders. And since the early days of transplantation, there is this high degree of skepticism amongst experts that people who had alcohol-related liver injury could even abstain from alcohol, therefore benefiting. The exact origin of this rule is not completely understood, but this paper by Osrio is one of the original papers that talked about alcohol, the 6 months rule as a predictor for alcohol relapse. I have to say that this is a problematic paper for multiple reasons. It had 37 patients that they were looking at for this paper and 37 matched controls. It was interesting that in the paper they were fairly confident that after doing multivariate analysis that because only the 6 months rule was positive, that this is evidence for it as a rule to support the selection criteria. But having said that, there was multiple issues here with this paper. The urge to drink and the number of people that were drinking was actually the same between the two groups. So those who were transplanted for alcohol-related liver disease and those who were transplanted for a different reason, which makes me think if they received adequate follow-up or education regarding alcohol use. The other interesting piece is that for the people who received transplantation for alcohol-related liver disease, only 60% of them believed that they have alcohol use disorder. And where this 6-month sobriety rule really came into play was that there were 2 people who did not have sobriety of less than 6 months. Both of them relapsed. So to make a rule based simply off of 2 is questionable. Furthermore, I'm not sure from reading the paper exactly what they meant by recidivism. Is it, a slip, or is it a true severe relapse? So all in all, a lot of problems with this original paper that supported the 6 months rule. But having said that, the 6 months rule has been rationalized in the sense that it does 3 things. It allows recovery for alcohol-related liver injury that may obviate the need for transplantation. It also helps to identify patients who are at risk for alcohol relapse after transplantation, and it's rationalized as a way to ascertain commitment to abstinence by having people participate in alcohol rehabilitation. So after that original study, there has been multitude of other studies. In fact, the 6 months or sobriety pre-transplantation has been is the most common factor that is studied for predicting alcohol relapse. This is a wonderful summary done by a systematic review, and here you can see that it is very inconsistent. Abstinence before abstinence before transplantation, whether or not that actually predicts relapse. And also complicating issues is that a variety of these studies will have different cutoffs and they'll have different definitions for what it means for relapse. Again, are we talking about slips or are we talking about significant relapse? And even if they are significant, there is a huge range in confidence intervals. So it's difficult to interpret some of these studies. And they'll also find conflicting data. There's some that will say that 6 months doesn't predict, but 1 year does. So yeah, again, rather difficult to say. But all in all, in terms of the 6 months rule, it is problematic for multiple reasons. It's an overemphasis of, frankly, just a single data point. And this single data point is not supported by the current literature in a consistent way and in a way that justifies its almost black and white application and cutoff. The 6 months rule also does not acknowledge the other biopsychosocial factors of alcohol use disorder. It puts a huge emphasis on this specific period of pre-transplant abstinence in a way that allows it to predict future abstinence, but it does not accommodate our current understanding of alcohol use disorder, and it does not address therapeutic needs required to achieve successful abstinence for individuals. For example, development of insight into addictions or helping people to manage internalized shame associated with addictions, and it doesn't teach people coping skills for identifying triggers or managing cravings. Frankly, the 6 months rule is also an arbitrary cutoff. We know that brief time-based sobriety rules are not consistent with known course of alcohol use disorder. Alcohol use disorder is a chronic, relapsing, remitting disease. Although there is some evidence suggesting that longer periods of abstinence may be predictive of future abstinence, but for an individual with 6 months of abstinence, there will only be some incremental reduction, if any, risk in comparison to 4 months of absence, 5 months of absence. You know, what is it about 4 months or 5 months that is hugely different than 6 months of abstinence, strictly speaking, if we're talking about cutoffs? Most frustratingly, the strict adherence to the 6 months rule penalizes some patients with recent drinking who are at otherwise very low risk of relapse. And we'll chat about some of the other protective factors at the end. So this, with that recognition of the rigidity of the 6 months rule and the lack of evidence supporting it, this is one of the seminal prospective multi-center studies that's done in France and Belgium. It really transformed the landscape of liver transplantation for alcohol-related liver disease, and has helped to change some of the thinking surrounding it. So this study demonstrated that transplantation before 6 months of absence was life-saving in patients with life-threatening liver failure due to alcohol-associated hepatitis. It involved 7 transplant centers, and the number of people that were transplanted was 26. It involved a highly rigorous selection criteria for patients who were not responding to steroids or were declining in health. The inclusion criteria was you had to have severe alcohol-associated hepatitis with Mastery discriminatory function more than 32. You have to be shown to not be responding to medical therapy. The presentation of acute liver failure has to be the first liver decompensating event. And then you have to have the proper psychosocial supports. There cannot be severe untreated psychiatric disorders, and there has to be a commitment from patients and family for lifelong total abstinence of alcohol. And the selection process was also very rigorous. It involved 4 circles of care. The first circle was nurses, people at bedside, resident fellow. The second circle involved addiction specialists. Third circle was hepatologists, and the outermost circle and the final circle are those who are providing the surgery. So all 4 teams had to achieve consensus before this person can be listed. The way that the study went was that 26 patients received liver transplantation. I couldn't quite tell from the paper exactly how many patients were referred, but 2 centers did report their total number of referrals. So it was the Lille and Brussels Center. So in there, they had 230 referrals, and they transplanted out of these referrals 18. So that's only about 7%. 90% of people for their referrals, they did say though, were excluded because of an unfavorable psychosocial profile or family profile. And the huge portion was also excluded because it was felt that they have a predisposition to relapse. These people that were transplanted were incredibly sick with MALD of 3-4. And another interesting thing that they found was that because of their selectivity of their criteria, the resource that was used to transplant these patients were not expensive. This is the survival data for what they've done here. And you can tell that patients who were transplanted, so this is the gray line, patients who were not transplanted, these are the matched controls. Survival is in percentage here on the y-axis, and time is on x-axis. So at 6 months, there is a very obvious benefit in terms of survival. Frankly, of the people who are going to pass away because of the severe illness would have passed away at about the 2 months mark, 2 to 3 months mark, and they died because of complication of liver disease. Of the people who passed away in the transplant group, 5 to 6 deaths were associated to infection after the surgery. And in the 2-year mark, you can see that patients here are doing quite well. So what about alcohol relapse in this population who did not abstain for 6 months? It was found that the relapse rate was actually low. 3 patients did resume drinking alcohol, 1 at basically a year, 2 of them are about more than a year or 2, and the last one is about 3 years after transplantation. They did have ongoing support through addiction specialists. 2 patients unfortunately continued to drink, whereas 1 drank occasionally. And at the time of the publication of this paper, there was no changes in graft function yet. The US data across the Atlantic is also quite supportive. So I'm referring to in Weeks and Lee in particular. So looking at their abstinence prior to liver transplantation, again, this is for alcohol-associated hepatitis. So they transplanted in the same way, you know, the sickest of the sick. So also, again, less than 30 days through that exceptional pathway. Very, very sick, MELD score of more than 30, almost 40 at the time of transplantation. Excellent 1-year survival, and return to harmful drinking is still within that typical 10 to 20% relapse. And again, you know, even in the US study for alcohol hepatitis, the selection criteria is very strict. It is basically almost the same as the initial French study, so very selective. What about the Canadian context? So I'm sure that everyone has heard that there was a patient, Mark Selkirk, with alcohol-related liver disease who died in 2011 after denial transplantation based on the 6 months rule, and his wife, in joining with a wife of another patient who passed away under the same rule, challenged this in the Ontario courts, filing the challenge that he was violated the rights and freedoms guaranteed under the Canadian Charter. In response to this, Tranium, which is the Ontario transplantation program, launched a 3-year pilot program to gather evidence of whether or not there is a scientific basis for the 6 months rule. The paper that was published from it came out in 2021, and it was a prospective pilot program for patients with alcohol-related cirrhosis, hepatitis. And so what it was is it was 700 referrals, 14% that was listed for transplantation, 6% actually received transplants. Again, people did quite well, and they found that interestingly, that length of absence was not a predictor. And so what is it in the Canadian, or sorry, what is it in the BC context? So in BC, there is no longer the minimum period of absence, aka the 6 months to accept referrals. Evaluation done for transplantation is performed holistically. But having said that, there still must be no significant medical comorbidities that will impact the success of transplantation. Psychiatric comorbidities will still need to be stable. Patients need to have good insight into the role of alcohol in their underlying liver disease, and they must have strong psychosocial support, stable finances, commitment to lifelong absence, and risk factors for relapse are assessed via standardized assessment systems and also addictions specialists. So in particular for alcohol-associated acute hepatitis, the patient still, it still needs to be the patient's first presentation for liver disease secondary to alcohol. And they must not have prior knowledge or documentation of alcohol-related liver disease or any medical conditions caused by alcohol. This would include pancreatitis, withdrawal, falls, where a physician has told the patient that alcohol cessation is for maintenance of health. This patient must also have severe presentation of alcohol-associated hepatitis without adequate response to medical treatment. A second common scenario may be that they have decompensated or acute on chronic liver failure for a patient with alcohol-associated cirrhosis, and the time base, that was valued before, again, it is no longer there. So in patients like this, where there is severe decompensation, they're inpatient, they have high MELD, or they suffer from hepatorenal syndrome, etc. Alcohol cessation after diagnosis of cirrhosis is still important. But if the patient did not have time to benefit from alcohol cessation, for example, if they stopped drinking alcohol 4 months ago, they have their underlying depression or triggers well addressed, but they had ascites at the time, and now they have infection of their ascites, they're decompensated, they're here in the ICU on pressors, that would not exclude them because they did not have time to benefit from their alcohol cessation. But if someone is coming in with acute on chronic liver failure because of ongoing alcohol use, this patient will not be accepted for referral. For those who are interested, the Canadian Transplant Association put out a white paper for ethical consideration of transplantation for alcohol-related liver disease. The white paper is meant to offer a general framework for evaluating the relevance of the 6 months absence rule for alcohol use, but also it lays out some ethical principles to consider for liver transplantation in this population, and it goes through details the complexity of this process. Certainly an excellent read, but a couple of things that really jumped out and spoke to me, and also multiple things that it's also compatible with what was brought up with attending staff who specialize in addictions who brought up, and that is this idea of justice and stigma. The idea of justice as in offering equality of opportunities. And it was just striking in the sense that this concept would involve taking into account how there is multiple psychosocial determinants of health, such as poverty, housing, education, gender, racism, location of where you may live, whether you're urban or rural, that are associated with developing substance use disorders like alcohol use disorder, but the same things are also judged in when we're evaluating whether or not someone may be a candidate for liver transplantation. So the same thing that would cause the underlying disorder would be the same thing that would disadvantage them for evaluating them for transplantation. And further to that is this underlying issue of stigma. So a small number of patients who have alcohol use disorder would ever be referred to a transplant center for evaluation. So I suppose I'm saying that as a recognition that there are inequalities in society that predispose to alcohol use disorder, and it's important, I think, as addiction providers to recognize it. And so when we identify that small portion of people who would meet criteria, who may benefit, I think so much more important that we advocate for them and discuss with them that liver transplantation may actually be a reasonable treatment, as I find in my own practice that a lot of times people were not aware. But of course, you know, having incredible respect for autonomy as well, in the sense that not everyone who has end-stage liver disease would want or would be a good candidate for transplantation, and is still in our wheelhouse to support them as addiction medicine providers. So that goes into the last section, the final section, that is, what's the role of addiction medicine providers in the context of liver transplantation? And this, and I think just, I mean, the first thing is just so bland, advocacy and support for patients, but I do think that we can provide this very crucial role, and this role is acknowledged in multiple papers from the transplant perspective as well. We, as addiction medicine providers, have been named multiple times as the source of how, a source or like a key colleague in assessing patients for liver transplantation. I think we can fulfill that role, but with some caveats as well. So I think we should and must provide holistic evaluations where we look at their alcohol use disorder, outline the severity that it is, and but even more crucially, I think identifying the risk factors associated with relapse and determine which of these are modifiable and work with a patient to address it. And I think for our transplant colleagues, perhaps outlining which of these risk factors we're hoping to address, just so they have some insight into what we're thinking. Just as importantly, I think also identifying the protective factors. Well, unfortunately, we all live in a constrained system where we don't have as many resources as we like, and there's significant gaps in care, but we should identify the patients who organically do have these supports and bring it to the attention and outline it in our consult, so that it can be known that they have characteristics that would be productive and therefore may be helpful for our transplant colleagues when it comes time to discuss who is for listing. In terms of what particular risk factors are associated for relapse, this is tricky because of the same issues that we chatted before with the 6 months piece. So studies will fluctuate in what they show is a risk factor and what they do not. So in many ways, most of the factors I have listed here are inconsistent, but there are some general through lines in what seems to be associated with relapse. So for example, unstable psychiatric comorbidities, stress management, poor social support, poor history of compliance, treatment, or insight of their underlying alcohol use disorder. There are some genetic components like family history, or perhaps female gender, and also interesting tobacco use. But again, I just want to say that whether or not they are actually significant in multivariate analysis of these papers fluctuates, it's inconsistent. And also when they are identified as a factor that does play a role, the odds ratios and the confidence intervals around these odds ratios can be quite broad. So it can be anywhere from example like 1.01 all the way to 5. So or it can be like 1.10 to for example 40. So hard to interpret, but still I think the crux of it is there, and I think these risk factors are would confirm what we are already suspecting clinically. And another question that we always have in medicine in particular is, well, if an individual factor can't do it, can we put it together and make a rule and make it into a tool that predicts? Unfortunately, there is no such easy answer. A number of groups have attempted to codify the pre-liver transplant psychosocial assessment into a prognostic score. These scores, at the end of the day, if you read through them, they do have common features, such as do you have a spouse or partner, basically touching on psychosocial supports. Do you have insight? Do you have history of poor adherence to, for example, treatment? But at the end of the day, they are not validated. They are not for use in isolation, and they're certainly not a substitution for a holistic evaluation. What we can do for people with alcohol use disorder, though, is to provide psychosocial interventions, pharmacotherapy that is rooted in best evidence. Dr. Bott recently just showed me a paper by Vanier et al. That showed a retrospective cohort study of basically 10,000 patients, 10% of whom who has alcohol-related liver disease, and medical addiction therapy has actually been associated with decreased incidence and progression into alcohol-related liver disease. And you can also see from the paper that pharmacotherapy for alcohol use disorder is actually associated with lower incidence of hepatic decompensation in patients with cirrhosis. Of course, pharmacotherapy for alcohol use disorder in a context of steroid decompensated cirrhosis is a whole topic unto itself, but it is important to recognize that we can still provide that role and that level of support. And then the other important piece that comes up is the idea of smoking cessation. So patients with alcohol-related liver disease who receive transplantation actually die more commonly from de novo malignancy or cardiovascular disease. Smoking is so very much associated with both of these, so it's a very important risk factor to address in promoting health in our patients. And it's actually well established in the literature too that patients with alcohol-related liver disease are more likely to smoke. The other piece of relapse prevention, I think, is just in us being there for the patient, following up, and being involved in the care. There is evidence suggesting that integrating providers, so the focus in substance use care into the transplant team, actually decreases the risk of alcohol relapse after transplantation and may even have mortality benefit. We know from our literature that active follow-up with the addictions team before and after transplant is actually associated with decreased relapse. So, you know, in one study with Rodrigue et al., the risk of relapse is 16%, whereas those who did not follow maybe even 41%. We also know that continuously engaging with a multidisciplinary team, so not just doctors, but more importantly, multidisciplinary team, shows that they are less likely to relapse. In fact, there is a study suggesting that the less time you spend with a multidisciplinary support, the more likely you are to relapse. But having said that, maybe that is a predictor that those who are about to relapse don't reach out. So there is also a role for novel ways of engaging patients so that they do not, so that we do not lose contact with them. There is a pilot study that looked at an 8-week method of sending texts to patients with alcohol use disorder, and they've had tremendous success in that way. So takeaway points, and that is liver transplantation is an important tool that helps patients who are incredibly ill and have end-stage alcohol-related liver disease. But having said that, should only be for those who would benefit from transplantation and should receive very comprehensive holistic workup. The 6 months rule is not an accurate predictor of alcohol relapse after transplantation. Frankly, there is no single predictive factor or prognostic tool that can reliably predict alcohol relapse. Alcohol use disorder is a very complex biopsychosocial disease that is difficult to assess in this way, but addiction medicine providers is an important piece of the puzzle in providing ongoing follow-up and assessment before and after transplantation. These are my references. And also, I would like to sincerely thank Dr. Samad, who is a hepatologist in Saskatchewan involved with transplantation, and also my colleague, Polly Cooper, who's very kind in giving me time to chat with her about the process, and Dr. Marquez, who is so incredibly patient with me in explaining the pathway here in BC, and who will also kindly promise me to clarify anything that I've not covered in this presentation as well. So thank you everyone for your time.
Thanks, Vic, for that. I'll give everyone a minute to collect their thoughts and put any questions in the chat, or raise your hand if you'd like to have one answered. Not seeing any questions in the audience at the minute, but so I'll ask one. So when you, like, taking everything you sort of learned and sort of looked into and researched, what do you think we can do when we're seeing patients perhaps on a sort of individual basis, potentially not directly for this purpose, but do you think there's something we can do to advocate or identify risk factors, or sort of promote this idea of potentially be considered for a transplant when we see patients for alcohol use disorder in the hospital setting, perhaps?
I think it comes back to, I think in many ways we are already doing it, but I think also in particular addressing more of the psychosocial pieces, like for example, that involvement of family, especially if we're going to consider them for transplantation in the past, it really highlights the importance that they're connected somewhat socially, as this is something that transplant will look into whether or not, there's a community behind this person, but also digging much more into the triggers for use, moving beyond just pure pharmacotherapy, but really examining, is there an underlying mental health disorder that could be driving this, and what are the psychosocial consequences of this as well. And I think for myself, There's multiple times when I was chatting with a patient who is young, 40 to 50 years old, and just have never really been told or thought about how transplantation may be a viable option, though I would never say that they could that they would qualify, because I think that's not in our wheelhouse, and that's not something we should promise. But just to introduce that idea, there's been multiple times where I've come across patients who are just surprised, who just simply thought that they were going to die, and that was the end of that. And I'm saying this because there's a couple of them who have frankly just told me that, it's too late. Having said that, it's never too late to quit. But if it is really incredibly severe, there is a potential last line treatment for the select few. And I think it's important to be transparent and provide that information up front. I've seen people who, after I told that there is this potential last line treatment option, that they seem to have more hope about the future. But having said that, I would say that when discussing this with a patient, there is a lot of caveats at play, and the patient should also be aware of that as well.
Yeah, absolutely. It's a very nuanced sort of topic to approach. There's lots of factors that play into it. I'll give it another minute or so for people to ask questions if they have any, but we are approaching 1 o'clock. All right, well, not seeing any more questions from the audience, but so with that in mind, thank you so much. That was a very comprehensive and very enlightening talk, and really, I think, reoriented me at least, and I'm sure everyone else in the audience as well, to so all the nuances that go into this and what we know and how we should approach these patients. So thank you very much, Victoria, and thanks everyone for joining us. And we look forward to welcoming you back during our next academic year when we pick up likely in August. Thanks so much.
Perfect. Thank you everyone for your time. Take care.